Great. Sounds good. Hi, everyone. Thanks for coming. My name is Chris Redmond. I am a rheumatologist with West Virginia University. I'm on the East Campus in Martinsburg, West Virginia. So thank you for joining me today. We'll be doing a whirlwind tour of vasculitis. And so this is typically how vasculitides are kind of divided up within the rheumatologic community. It's really by the size of the vessel involved. So starting with kind of from the left, large vessel vasculitis that usually involves aortas and branches off the aorta. Moving into your medium vessel vasculitis, meaning involving, I call them kind of organ penetrating vessels. So vessels that are going into organs, renal arteries, carotid arteries, mesenteric arteries, things like that. And then you have your small vessel vasculitides or vasculitis conditions, where these are vasculitis that affect blood vessels that are already inside an organ, skin, lungs, kidneys, things like that. And then you have some that we'll talk about that aren't represented in this diagram that also involve the venous system as well. So objectives are to identify the characteristics of the major vasculitides, presenting symptoms, organ-threatening manifestations, appropriate evaluations, treatment, and some complications or considerations. Since this is primarily focused on, I guess the talk is focused more for primary care, I'm not going to go too deep into the woods about the treatment, kind of just initial first steps and what we typically use. You could kind of do a whole talk about each vasculitis and its treatment by itself, but I don't think the minutia of that is very relevant to today's talk. So we'll start with ANCA-associated vasculitis. Sorry for the blurriness there. Anti-neutrophil cytoplasmic antibody vasculitis. Really three major types: granulomatosis with polyangiitis, formerly called Wegener's granulomatosis, microscopic polyangiitis, and then eosinophilic granulomatosis with polyangiitis for previously Church-Strauss. Relatively rare, I guess 0.5 to 20 cases per million cases. A wide variety of symptoms. These are kind of features of ANCA-associated vasculitis in general. Pulmonary renal involvement is very, very common. So lung nodules, renal failure, severe hypertension. You can have CNS involvement with strokes or meningitis. Ulcerations and skin rashes are very common as well. We'll see pictures throughout of like palpable purpura or leukocytic vasculitis and things like that you can see in ANCA-associated vasculitis as well. Rarely can sometimes involve the GI tract as well. And then for certain types, upper airway involvement is very common as well. What is ANCA? And so this is what ANCAs are. They're anti-neutrophil cytoplasmic antibodies, so neutrophils in the cytoplasm, or antibodies in the cytoplasm of neutrophils. Two major groups are perinuclear and cytoplasmic. So perinuclear, you can see here, the staining is just around the nucleus. Cytoplasmic, you have kind of a more diffuse staining. So that's how you identify those types of the P-ANCA or C-ANCA positivity. In terms of MPO or PR3, that's an ELISA, again, to figuring out exactly what specific protein that the antibodies are directed against. You can see here the sensitivity and specificity is relatively high, or the specificity is relatively high for C-ANCA and P-ANCA, but you can have ANCA-negative vasculitis as well, which is usually diagnosed by biopsy or clinical symptoms. So it does not rule it out by any chance. False positive rates vary widely, a little higher for P-ANCAs and MPO than C-ANCAs and PR3. And also, if you have an ANCA without an MPO or vice versa, a lot of times that may be an indication of a false positive. But really, the false positive rate is really dependent on the your kind of expected, your clinical scenario. The higher the pretest probability, so the more likely the higher your suspicion for ANCA-associated vasculitis, the lower the false positive rate. So I think it's kind of in the eye of the beholder that tells you this is still a clinical diagnosis. I should have said all the vasculitides we're talking about today, there's no single diagnostic criteria for any of them. So it is really up to you and your rheumatologist to come up with these diagnoses based on the clinical and laboratory information provided. So if you look at GPA, again, that's typically about the majority of those are associated with C-ANCA or PR3 positivity. You can have MPO as well, and sometimes you can have negative. Microscopic polyangiitis is typically more MPO positive, again, slightly higher negative rate. Eosinophilic granulomatosis with polyangiitis, about 50% will have antibodies, mostly MPO, and 50% will be negative. Renal limited, this just means a vasculitis that is just isolated to the kidneys. Most of those are MPO positive, and then you can have a drug-induced that can be both, or it can be dual positive as well. ANCA is not just seen in patients with ANCA-associated vasculitis, lupus, endocarditis, ulcerative colitis, primary sclerosing cholangitis, and cystic fibrosis can all have these. The atypical ANCA is typically meaning they stain positive for ANCA, but not for NPO and PR3. And so other diagnostic utility. So again, renal involvement is really high. The histology for this, like I said, the is pretty classic. It's important to get if you think you have pulmonary or renal involvement. It helps determine prognosis. You can have focal disease, crescentic or mixed disease, and then sclerotic disease, which is kind of the worst. The key feature is pauci-immune. So when you stain these cells to look for antibody deposition, there's very little antibody deposition. Compare that in contrast to patients with lupus or other conditions where you'll have a lot of antibody deposition. And so that's kind of the laboratory evaluation. How do we treat it? Severe disease, it's rituximab, which is a B-cell depleting therapy with steroids, and then you give conventional DMARDs, things like azathioprine, methotrexate, CellCept, stuff that's used for lupus, vasculitis, and multiple conditions in rheumatoid arthritis. If they flare, then you can use a chemotherapy called cyclophosphamide, or you can actually use that up front too for induction therapy. And really, if you flare, you kind of switch. So you do rituximab if you did cyclophosphamide, or vice versa, kind of whatever didn't work before you try the other thing. Non-severe disease, if it's just in the upper airway or in the skin, so not kind of organ or life-threatening, you still do steroids, but you can do methotrexate, azathioprine, those medications up front, and then just continue it as maintenance. Two unique features of these conditions. So Avacopan is the first FDA-approved medication that was specifically made for ANCA-associated vasculitis. It's a C5a receptor antagonist, and so it's not used in place of any of the specialty medications. It's actually used in place of the steroids, and it's shown to be pretty successful. I will say a couple things. There has been some concerns about transaminitis in these patients on Avacopan. I think it's still appropriate to use in the right clinical setting. It is very hard to get to because it's a hard sell for insurance companies to say we're not going to use steroids, but we want to use this kind of new novel medication, which is a bit more expensive. But if you have a patient who can't have steroids because they have severe diabetes or other concerns, GI bleeds, things like that, Avacopan is a potential medication to use. Mepolizumab and Nucala is another medication that's used for EGPA for non-severe disease. So if they have kidney failure, severe respiratory failure like diffuse alveolar hemorrhage, then you wouldn't use this. But if they have kind of more of that asthmatic picture that we'll talk about in a second, then you can use that instead. You can use that in addition to the other medications. And so this is kind of my overview of how I think of ANCA-associated vasculitis. So, if you have a patient who has pulmonary infiltrates, diffuse alveolar hemorrhage, glomerulonephritis, hematuria, palpable purpura on exam, scleritis in their eyes, that sounds like an ANCA-associated vasculitis patient. I mean, for all intents and purposes, from us primary care, defining exactly what type it is probably isn't the most important thing. Just figuring out those features. The features at the top on the green there is really saying, I'm concerned this is a vasculitis patient. And obviously, if they have major organ involvement, they need to be treated relatively or immediately. But there's some features that help divide them out. So patients in GPA, it can be more of an insidious onset. People of more European descent versus MPA, which is usually more East Asian Asian descent and with an acute onset. And EGPA, in terms of epidemiology, is just extraordinarily rare. So that's kind of on the rare end of the spectrum. The other two being much more common. The big defining symptom of GPA is upper airway disease. Saddle-nose deformities, chondritis, tracheitis. Those are things that you'll see in GPA and really not the other conditions. EGPA, you can have a little bit of kind of upper airway polyps, but you will not have the large saddle-nose deformities. And then for MPA, you have no upper airway. For EGPA, eosinophils, think asthma. So these are very kind of atypical patients with severe late onset asthma. Monorex multiplex, so someone who comes in with a foot drop. It can be any of these conditions, but it's much more common in EGPA than other cases. You can also see it in GPA as well. As we talked about the antibody differences between the different groups. And eosinophilia, again, EGPA, eosinophils, you'll have some a good proportion of patients, I forget the exact numbers, I apologize. You'll have hypereosinophilia as well. And on histology, if it has a G in the name, there'll be granulomas. If it has an E in the name, there'll be eosinophils. If it has neither, it will just be a necrotizing vasculitis typically, and that's how I think about it. So EGPA, granulomatous inflammation, or GPA, I'm sorry, granulomatous inflammation, EGPA, eosinophils, and granulomatous inflammation. MPA, you have no E or G in the name. It's just a necrotizing vasculitis. Steroids and rituximab are kind of across the board, and then consider mepolizumab as well. So, if you're primary care and you're concerned about this, obviously get inflammatory markers. You can get the ANCAs, but really you need to look for major organ-threatening disease that needs to be treated abruptly. So UAs to look for casts, CBCs to look for severe anemias, look for AKIs and your CMP. If they have pulmonary disease, chest X-ray or CAT scans are appropriate as well. And these patients want to see all of them should see a rheumatologist. If there's concern for kidney involvement, they should see a nephrologist. Most of them should see a pulmonologist at some point, probably as well. And if you're concerned about EGPA or any of them, having them see an ENT is good because some of the ulcerations or findings in the upper airway are difficult to see on direct visualization with just like an otoscope. You really need a kind of a laryngoscope to go back there and really look at the kind of posterior upper airway. And really, audiometry is something these patients should be getting annually. So if you notice they haven't gotten that with the rheumatologist, I usually get, especially for my EGPA patients, once a year, annual hearing screens, because it's something that can kind of be silenced, no pun intended, for a long period of time, and then all of a sudden they have chronic hearing issues and it can be a sign of disease activity that can be difficult to assess on history and physical exam. So some things that I was thinking about for patients with ANCA-associated vasculitis for primary care, do they need pneumocystis prophylaxis? That's a big question. If you look at studies done 20 years ago, it was a very huge, major concern, and the incidence was really high. But in more recent studies, a lot of them, they haven't seen anybody with pneumocystis. The questions about whether or not that is what's associated with that is tough to say. Other conditions such as HIV, where pneumocystis was more prevalent, I guess, or is more better controlled. So maybe that's contributing. It's really difficult to say. But one thing that is true throughout the literature is that pulmonary disease, scarring, lung disease, cavitary lesions in the lungs, huge risk factor. So those patients probably should consider it, but it's something you can discuss with your infectious disease and rheumatologist. Should they receive regular vaccines? Yes to vaccines. If they're on methotrexate or rituximab, you should hold those medications for 2 weeks if possible. Now, ideally, you wouldn't hold the rituximab. You just, because it's only given every 6 months, you would just give the vaccine at least 2 weeks before your next rituximab dose. You can consider deferring the vaccine, non-live influenza vaccines, if they're on a high dose of prednisone, just because it will be less efficacious. They should receive pneumococcal vaccines. Live vaccines, again, in patients on chronically immunosuppressed, generally avoid. If it is a must, sometimes you can hold the medications for 1 dose interval and then 4 weeks. And then you can give the vaccine. But most vaccines in the United States are non-live that are required for adults. And in kids, I'm a pediatric rheumatologist as well. Sometimes we just delay the vaccine schedule as well. But if my patient's sick, just tell them you can treat these patients for your illnesses in primary care, but have them talk to the rheumatologist. They'll manage the medications. Typically, if it's a severe infection, we hold the medications like the methotrexate, azathioprine until the infection is improved or appropriately controlled with antibiotics. Okay, World 1 ANCA-associated vasculitis. Moving on to the other small vessel vasculitides. So this is IVGA vasculitis, formerly Henoch-Schönlein purpura. It's an immune complex small vessel vasculitis with high IgA levels sometimes. Presenting symptoms, it's usually after recent viral GI illness. It can be within the span of several months for illness. Usually children and young adults are more commonly seen, but it can be seen at any age. Palpable purpura on exam, which is kind of like here, these kind of raised lesions that are non-blanching. They can have arthralgia and intermittent abdominal pain from gastric intussusception. Intussusception is much more common in children than adults. Renal involvement, which can be relatively silent, is again much more common in adults than children. And it's kind of the most severe consequence of this condition. So if you see in adults, again, much less common, but need to watch closely for renal involvement. If they have a skin biopsy, if possible, it doesn't need to be done in all patients, but sometimes it's beneficial, especially if there's a questionable of the diagnosis, especially in adults. A lot of times, even if the IgA levels are elevated, I've seen this in patients with malignancies and things. And so making sure that you know what you're dealing with. Sorry, I forgot. The renal biopsy too, if there's concerns for renal involvement as well. So, hematuria, AKI, things like that. Sorry, I got cut off there. Treatment for mild disease really can just be supportive. NSAIDs. Prednisone is given to these patients a lot just because of the polyarthralgias, and it does help. It does not help at all with preventing kidney disease. But if they do develop kidney disease, usually prednisone or steroids is the first-line therapy, and then if the renal disease persists, you can consider azathioprine or rituximab, other medications that your rheumatologist will manage. So what do we do? How do we monitor these patients? For pediatric patients, it's usually blood pressures and UAs weekly for 2 months, and then about monthly for about 4 months. So they see about 6 months of evaluations, because typically within the first 2 months of after disease is when the renal disease will occur. And then in adults, usually it's just blood pressures and UAs every 3 months for about a year, just to make sure there's no renal involvement. These symptoms can recur with recurrent illnesses. So if they get a GI infection again, a viral illness, they can get some of the arthralgias and the rash again. Typically, with each, and I believe it's in anywhere up to about 30% of a third of patients, though can develop recurrence. But usually the symptoms are less, and every time it recurs, the symptoms become less and less severe. So you can just provide, and again, if there's no signs of renal involvement, you can just kind of provide supportive care. Here's some other immune complex vasculitis. So IgA nephropathy or Berger's disease. This is typically associated with asymptomatic hematuria. So some type of kidney disease from asymptomatic hematuria glomerulonephritis seen in chronic smokers. You also have kind of, again, the palpebral lesions with, and then in the biopsy of the skin, you'll see IgA deposition. Smoking cessation and treatment with ACE inhibitors or ARBs is usually the primary therapy. Cryoglobulinemic vasculitis, relatively rare, but sometimes seen. This is commonly associated with hepatitis C infections. Can be without it though too. So patients can just have positive cryoglobulins. Important thing for this testing, if you have a remote lab nearby, it may be difficult to do this test because if the tube gets to room temperature, the test is pretty much invalid. It needs to be put in under in kind of like a sand warmer until it's done. Kind of a poor man's cryoglobulin test is a rheumatoid factor. If it's severely elevated, that it can be a sign of cryoglobulinemia. They'll have purpura or glomerulonephritis. They can develop peripheral neuropathy. It can be pretty severe. If they have hepatitis C, typically nowadays you treat hepatitis C, which is virtually curable, and the symptoms significantly improve. But if it's non-hepatitis C associated cryoglobulinemic vasculitis, it's steroids, rituximab, and similar medications. Hypochlorogenic urticarial vasculitis is a condition where patients will have urticarial lesions. And the interesting thing about these lesions is, patients can develop urticaria for any reason for over 24 hours, but the specific lesions will stay in one spot for greater than 24 hours. They typically have the positive C1q antibody and low C3, C4. Some of these can be associated with lupus or precursors to lupus in some patients. For mild disease, you can just treat them with anti-inflammatories and dapsone sometimes. For severe disease, again, the medications we've seen over and over again, steroids, methotrexate, azathioprine, things like that. This is a test for this on the imaging on the left. It's called diascopy. It's something that dermatologists may be more familiar with. So you can see this patient has an urticarial lesion, but if you actually put a slide over the lesion, and you can see the blanching of the lesion, but what's left is this small center of purpura. And so if this patient just had urticaria from an allergic reaction or something else, the entire lesion would blanch, but you kind of reveal the purpurate lesions of the vasculitis underneath of it. So if anybody actually has slides around their office anymore, that's something you can do relatively easily and cheaply in the office. And then finally, anti-glomerular basement membrane disease or Goodpasture's disease. Again, this is a pulmonary renal vasculitis. Can also have some neuropathy as well. Positive anti-glomerular basement membrane antibodies are very common. And you can have biopsy showing antibodies within the glomerular basement membrane of the kidneys as well. This is one of the kind of conditions where we still use plasmapheresis regularly. Steroids and, again, rituximab and similar medications are used as well. Okay, so that was a kind of a whirlwind of small vessel vasculitis. Before we move on to the medium vasculitis, I just want to talk about Behçet's, which can involve small, medium, and also the veins. And so in Behçet's, it's a variable vessel vasculitis. So our arteries and veins are both involved. Presenting symptoms are kind of oral ulcers, so usually they're HSV negative. Oral ulcers here, and then genital ulcers typically around the labia majora and the scrotum, again, swab for HSV negative. Pathergy is a common symptom, so that's when you put a needle under the skin, so subdermal injection, or placement of a needle, and you develop this kind of raised area afterwards. Sometimes people get this with blood draws. You can get panuveitis, relatively common too, so these patients need to be screened by an ophthalmologist regularly. Erythema nodosum like lesions are very common as well, and you can get thrombophlebitis and DVTs and things of that nature as well. You're concerned about limb ischemia, vision loss for severe disease, strokes, and you can actually have CNS inflammation of the midbrain that can cause encephalopathy, coordination issues, things like that. There are certain genetic tests that have been associated with this, particularly HLA-B51. So another HLA, not just the 27. That we think about with ankylosing spondylitis, but in terms of what's the appropriate evaluation right up front, these need to be swabbed to make sure they're not infectious. And then ESR, CRP, testing for ANCAs and rheumatoid factors for rheumatoid arthritis, and also for cryoglobulinemic vasculitis. These patients can be treated with steroids, colchicine, azathioprine. And the steroids and colchicine are usually first up, and then azathioprine, TNF inhibitors, and other chemotherapy agents for severe disease or refractory disease. Okay, so then moving on, polyarteritis nodosa. This is a classic medium vessel vasculitis. Relatively rare. It was much more common. A lot of patients previously were put in this camp that are now known to be, once ANCAs were discovered, are now classified as microscopic polyangiitis. You can have multiple symptoms, but again, this is affecting blood vessels going into major organs. So a lot of it's GI symptoms from mesenteric involvement, chest pain from coronary artery involvement, and hypertension associated with renal involvement. Cutaneous lesions to ulcerations, the levator reticularis, erythema. There's some subcutaneous nodules or kind of ischemic lesions as well can be seen. And one of the classic features of this is seen over here on the right. This is called the beads on a string appearance of the renal artery, previously done typically by angiography, but most nowadays we used to do a CTA to look for this as well. If you biopsy these lesions, you'll see necrotizing inflammation. Things to think about in this, if it's more of the symptoms rather than the actual vessel swelling, you can have endocarditis, cholesterol emboli, or antiphospholipid syndrome. Another thing that can cause a similar appearance in the renal arteries and other vascular lesions that can look like PAN would be fibromuscular dysplasia, although they wouldn't have any of the inflammatory symptoms that you typically see with PAN. So treatment and prognosis is a little bit interesting. So it's associated with hepatitis B infections. Cryoglobulinemic vasculitis, hepatitis C, PAN, hepatitis B. You treat the hepatitis B, usually improves. Doesn't usually come back. It's usually monophasic. Hepatitis B negative, again, first-line steroids, and then if it's severe disease, azathioprine, cyclophosphamide, rituximab. Again, prognosis for, if GI is involved, you have a higher mortality and hep B infection associated PAN, but otherwise, usually if you treat the hepatitis B, it usually improves. This is something called the 5-factor score. It's been around forever. A lot of people still reference it in terms of identifying patients at risk for severe disease. So these are some old studies done over, like 15 years ago now, where they looked at risk factors for survival and mortality in patients with PAN, and they found that these are the kind of the major risk factors. If you had none of these, your mortality was 20% at 10 plus years, which is relatively good. If you had one of these, it's still higher. You at 2 years, usually about 20% mortality, but that kind of levels off. 2 or more, though, you have a significant increase in mortality or decrease in survival, especially at 2 years. So these are the patients you would watch very closely. Consider those kind of more aggressive rheumatologic medications. Cogan syndrome. This is another variable vasculitis. Sorry, it's probably with Behçet's, but this can be small to large. So I kind of know where to put it. So I'll put it here. This is a difficult one to diagnose. The classic patient for this would be a young adult with acute eye pain and hearing loss. A rheumatologist can't diagnose this. You really need the assistance of your audiologist, ENT, and ophthalmology, because you need to find the interstitial keratitis, the uveitis, hearing loss, tinnitus, vertigo, things that are kind of difficult to evaluate in a rheumatology office. You can have vision loss or hearing loss, and actually a good proportion of these patients can have vasculitis. About 10% will have aortitis, which is what you can see here on this PET scan. This is a patient with Cogan syndrome. You can see they have just inflammation surrounding the aorta. It can be associated with Crohn's, ulcerative colitis, sarcoidosis, and even hypothyroidism, which I was shocked to learn, actually, but there is some associations there as well. Again, inflammatory markers are the only thing that really be that indicative of this, and that's relatively non-specific. So if the patient has the symptoms, they need the ophtho and audiology evaluations to confirm. Treatment would be steroids. Usually, a lot of times it improves, but then again, for refractory severe disease, especially if you have aortitis, you would be adding additional medications to that as well. Okay, so moving on to the true large vessel vasculitis. This one just labels Takayasu's arteritis. I'm going to briefly touch on GCA or giant cell arteritis, previously known as temporal arteritis. There's a whole other talk on polymyalgia rheumatica and GCA next month, so we'll get into the weeds of that a little bit more then. But this is a large vessel vasculitis, again, involving the aorta and branches off the aorta. Usually, large GCA is your old person large vessel vasculitis, or I guess older person. It's 50 plus years old. Typically, they'll have a temporal headache right here. So this is the classic. You can see this patient has the enlarged temporal artery. That can be present or not. One of the key factors I like to point out is that people get temporal headaches for a lot of different things. But if you have vessel inflammation from a from giant cell arteritis causing a temporal headache, it will be very tender to palpation. So if I have patients coming in and they're rubbing their temples saying, "Oh, this hurt, I have such a bad headache," it's not impossible, but that's less likely to be GCA just because that would be exquisitely painful to someone. So if it's called, and then you can have the same thing in your neck or your vertebral arteries, or your carotid arteries, in the back and the posterior anterior aspects of the neck as well. You can have loss. The classic symptom is like a TIA, so like a loss of vision. Or you can have jaw or limb ischemia if disease is severe, and it can be associated with polymyalgia rheumatica symptoms as well. Organ limb threatening stuff would be vision loss, limb ischemia, tongue necrosis, or stroke. Again, the only thing here would be ESR CRP. Temporal artery biopsies are very beneficial. It is patchy inflammation throughout the temporal artery, so you can have GCA with a negative biopsy. But if you have a positive biopsy showing things as shown up here with narrowed lumen, so lumen and kind of hypertrophy of the interstitial internal elastic lamina, lymphocytic infiltrates, and these kind of giant cells, which are like aggregated macrophages. That is pretty classic, and you're very confident in your diagnosis moving forward. Again, the correct answer for before doing any of this is if you have a high suspicion, it's just steroids immediately, even before the biopsy, and then medications after that can be managed by your rheumatologist. Complications you can develop. These patients are on steroids for a long time, and so these medications can cause some issues that need to be monitored for as well, such as weight gain, diabetes, things like that. So a lot of times I work closely with my primary care colleagues because I'm causing a lot of issues in patients with diabetes, because these are elderly patients with a lot of these symptoms or conditions anyway. So, all right. So the other one though, the kind of the younger version of large vessel vasculitis, Takayasu arteritis, is typically people less than 40. Big question right then: what happens between 40 and 50? Tough to say. It's really more of a clinical diagnosis. Usually the older you get, the more likely to have GCA. So if it's a younger-ish individual, usually it's Takayasu, but a lot of it will just be based on clinical presentation. This is a tough one to diagnose because it's very non-specific symptoms. People just have fevers, malaise, some neck pain. They can have claudication symptoms, which can be very difficult for patients to describe and for providers to kind of pick up on, even rheumatologists. You tell a person, so it would be fatigue with repetitive use just because of compromised blood flow to a limb. And so you ask somebody, if you're using your arm repetitively, does it hurt? Well, yeah, it hurts, but that could be bursitis, that could be arthritis, but it could also be claudication. So it takes a lot of digging to really get into it. I talk to a lot of people about very specific tasks like, vacuuming or whisking foods or things like that, and the time in which their arm recovers. If it recovers relatively quickly, maybe that could be a sign of claudication as well. Chewing food too, it can be a thing, and it's tough because people have TMJ that can cause pain, but it'll be more in the musculature as well. These patients are asymptomatic too, so sometimes you just catch them by the time they've developed, issues with blood flow that they're causing disease. Common cause renal ischemia, TIA, strokes, is you're not going to biopsy these patients because you don't get the temporal artery involvement that you do with GCA. So you can't really biopsy the aorta or major branches off of it. So really you're left with inflammatory markers and imaging. CTA and MRI are kind of still the standard of care, showing a kind of vessel wall inflammation. But this is a PET scan. There's some evidence, and I'm probably biased because this is kind of where I train. They're really kind of champions of this stuff, but it showed really good some good data showing that it can actually predict kind of when people are going to flare if you do a PET scan and where they're involved. So you can see this is a PET scan here. Anywhere you see this kind of lead, these are the kidneys in the brain where you're seeing a lot of glucose used. Obviously a PET scan is related with glucose. So anywhere there's a lot of activity, you'll see increased signal. So you see like in the brain here, but you see a lot in the aorta as well here. And you can see some in the subclavians as well. And this is the kidneys processing that too. So so that's not disease, but this is severely active disease, so I call it PET scan. So treatment: steroids, methotrexate, TNF inhibitors, medication. So steroids would be kind of your first line therapy as well. If someone is super concerned about Takayasu's and there's no contraindications, it all fits, steroids would be an appropriate empiric treatment. Okay, and so that's kind of the classic vasculitis conditions. This is a relatively new condition that I think was just identified 6 years ago, called VEXAS syndrome. VEXAS standing for vacuole. So this is a condition where people have myelodysplastic syndrome. When you biopsy, do a bone marrow biopsy, they actually have vacuoles in the macrophages and within the bone marrow. It's a mutation in this UBA1 gene that affects this E1 enzyme that's appropriate for cell turnover. It's X-linked, so it's seen in women, but much more common in men. These patients have autoimmune disease, so these are like chondritis, vasculitis, periorbital edema, urticarial vasculitis, things like that. And somatic mutations. I mean, this is not this is a genetic condition, but it's not something you inherit. It's something you develop over time, like cancers. And so, typically, your typical patient is an elderly male with myelodysplastic syndrome and some type of new onset autoimmune disease. Here's the list here. You can kind of go on and on, but cutaneous involvement, inflammatory arthritis, myositis, things like that, myocarditis. Any of these things can happen. It is treatments are relatively limited for it. And I will say before I go into treatment, one more thing is, we initially this was considered a relatively rare disease. The guys in our hospital in Pennsylvania, they actually did a large study of their entire group. They found the incidence of this in men over 50 is about 1 in 4, or prevalence is about 1 in 4,000. And in women, it's 1 in 26,000. So that's not uncommon. So something that needs to be kind of screened for, I think, much more than probably we're doing. Treatment is kind of limited. It's steroids, and then we're trying these different medications on it. There's some evidence JAK inhibitors like Xeljanz and Rinvoq and things like that work. Actemra is something that we use a lot for this as well. Stem cell transplant, something to be considered an early onset disease. Infection risk is really high. So, the overwhelming majority of patients, because this is a condition that causes cytopenias, lowers your white blood cell count, but also requires a lot of immunosuppressive medications. The overwhelming majority of these patients get some infection, and these patients should actually be on PGP and HSV prophylaxis. I actually have a patient admitted to the hospital right now with Vexus who's really in there for a MSSA bacteremia because one of his vasculitic lesions got infected, and so he actually underwent debridement this morning, and so it's a big thing. It is a very high mortality rate, but it's very mutation dependent. So these are kind of the most 3 common mutations in the methionine locus or amino acid that are known, and these are the ones you can commercially test for with the Mayo or Quest Labs. But you can see here if they have this valine one here, their 5-year mortality rate is just above 50%. The other ones, it's a bit steadier once you get past 10 years. And this is a lot of this data was before we knew about it, before treatment. So hopefully we're extending this out, but it's still kind of early days because this was really just discovered in the first papers were published in 2020. So. Interesting side note, this was one of the first conditions that was where the gene was discovered before the disease. This was discovered at the NIH where a very smart postdoctoral fellow in the genetics department said, or in the Human Genome Institute said, I think if you mutate this UBA1 gene, you will develop autoimmune disease. So then they scoured all these databases of information, and they found that in patients with the mutation, they were classically older men with some type of relapsing polychondritis, autoimmune disease, and myelodysplastic syndrome. And when they looked back and looked at the bone marrow biopsies, they saw these vacuoles. So it was actually a gene first diagnosis, which was kind of cool. So when should you consider this? So this is kind of an algorithm that was initially has been published. Again, older men, elevated inflammatory markers, any of these autoimmune disease symptoms, and if they have bone marrow vacuolization, if they get a bone marrow biopsy for MDS, or if they have an elevated MCV or thrombocytopenia, those are 2 huge risk factors. And with MDS or some type of cytopenias, then you should really be sending out the genetic testing. My kind of theory is if I have a new patient with vasculitis or chondritis and a man greater than 40 with an MCV greater than 100 and platelets less than 200, usually I'm testing for Vexus. Because, they're coming to me for this autoimmune disease. If I look for those, other things can do that, alcoholism, poor nutrition, other medications. But usually I'll run the testing anyway. It actually comes back relatively quickly too. So it's really relatively commercially available. So that's kind of everything. So this is just kind of what else can cause this. So tuberculosis can cause vasculitis. It's rare, but it can cause CNS disease in patients who are at a high risk, immunosuppressed. Ehrlichiosis can do it too. So if you have someone from the Southeast US or Central America with a lot of animal exposures, you can get the titers, they'll be positive. And sometimes they have large vessel involvement. Bacterial endocarditis is a huge one. This kind of, sorry about this pretty dramatic picture over here, someone who has levemosol-associated, ANCA-associated vasculitis. So these patients will have C or P or both ANCAs be positive, and they'll develop these really severe skin lesions that can involve the face and the nose commonly as well. It's associated with cocaine use because this is an anti-helminth agent that is used to cut cocaine apparently, and it can cause these lesions. So deficiency of adenosine 2, this is more in kids. It's a condition where you develop necrotic skin lesions and recurrent strokes. Is treated with TNF inhibitors, and the children do remarkably well. sarcoidosis can do anything, right? So that's why biopsies are so important. If you see non-caseating granulomas in these patients rather than necrotizing, you really need the biopsy that can do it. And then, every rheumatologist's favorite consult, is a primary CNS vasculitis. So, this can cause focal or diffuse deficits. Really, you need a brain biopsy to really confirm the diagnosis. I think most rheumatologists will agree to that, unless it's some extenuating circumstances that I've yet to see, and is treated with, again, pretty aggressive medications. So that's kind of just the other category that I've thought of. So thank you for listening. If there's anybody has any questions or concerns, or additional comments for some great experts in the audience too, I'd be happy to hear their thoughts.